We now proceed to our panel discussion. Joining Mr. Garilao and Undersecretary Panadero is an elected official who is on his third term as the municipal mayor of Del Carmen, Siargao Islands. In his seventh year in public service, he was able to bring in partners and collaborators from zero to more than 100. Del Carmen's partner-driven approach to development has resulted to tangible improvements in health service delivery. Let us all welcome Mayor Alfredo Coro II. Our next panelist is the former Secretary of the Department of Energy from 2012 to 2015. Prior to his cabinet appointment, he was a three-term governor of Leyte. His innovations in health have gained much recognition, including the Galing Likha Kalusugan Awards, organized by the PIDS and Center for Health Market Innovations. Let us all welcome Mr. Jericho Petilla. Our next panelist is the Medical Center Chief of the Southern Philippines Medical Center, a DOH-retained tertiary hospital in Davao City, Mindanao. He has implemented several business strategies, such as different forms of PPPs, to improve the efficiency, effectiveness, and equity of service delivery in SPMC. We call on stage Dr. Leopoldo Vega. To join our panel is the founding president of the I Can Serve Foundation, a Philippine-based advocacy group that promotes early breast cancer detection through multimedia platforms and community-based early detection programs, among other advocacies. Let us all welcome Ms. Cara Magsanok Aligpala. Our next panelist is the incumbent sectoral representative of the National Anti-Poverty Commission's Senior Citizens Sectoral Council. She has participated in different international gatherings for the promotion of the rights of older persons, including the UN. We call on stage Ms. Salvacion Basiano. Our distinguished moderator for this session is Dean of the Ateneo School of Medicine and Public Health. He is concurrent Executive Director of the Ateneo Center for Health Evidence, Action, and Leadership, a multidisciplinary center of the university which focuses on public health, research, and partnerships to strengthen the country's health system. He was Secretary of Health from 2001 to 2005 and directed the Department of Human Resources for Health at the World Health Organization in Geneva. We now welcome Dean Manuel Dairit.
Good afternoon, everyone. Before anything, I'd like to acknowledge the presence of Secretary Ben Diokno and Secretary Icona. Well, I might just begin by recalling the strategic directions that Teresa Martinez actually cross-cuts the issues today, particularly in this panel. The first one, if you remember, has to do with strengthening primary care. The second one has to do with strengthening local government engagement, which is actually what this panel is about. The third one is actually strengthening private sector collaboration. Okay? And the fourth one is actually increasing, you might say, the voice of patients and their choices. So when you look at our panelists, you can see how it's structured. We've got somebody from the municipal level, a mayor. We've got somebody who represents the provincial level, a former governor, and of course, Secretary of Energy. We have somebody that represents a tertiary level of care, a hospital director of a tertiary care hospital in Davao. And then we have representatives from the NGO and private sectors. We have Aligpala for breast cancer patients. And of course, anti-poverty, and I guess the elderly, Ms. Pasiano. So with this, I'm going to ask each one all of the panelists to comment on their views on, I guess, strengthening local government engagement. I mean, you can come in any order that you want, whoever's ready. But really mainly to think about those issues, since local government particularly deals with the issues of primary care. You're talking about the community, you're talking about the rural health unit, you're talking about the district hospital, that's all primary. And under the governor is the provincial hospital, which is secondary. So really here, you're talking about the primary level. And you're talking about the foundation for your health system. So can I call on, who wants to start? Former Governor Cotilla to start it off.
Thank you, Mayor Alfredo, for volunteering me to be the first one. Well, this is not the first time I've attended health forums and we focus on local government. In fact, Professor Garilao, this is not the first time we met. We met several times already. In fact, I remember one time you were giving a talk on Zwillig birthing clinics, and I can remember vividly that it was a Kamsur, one of the towns there. And then in your presentation, you had a similar presentation, but to the minds of the governor, parang pinapatamaan yung mga governor that this is your responsibility to take care of health. And you know, all the governors are looking at Professor Garilao. Then I can share with you now because I'm no longer a governor. After Professor Garilao stepped out of the stage or of the room for lunch, and then the governors, okay, banded together and said, "Kala niya madali lang to. You think this is easy? Try running." Okay? Because from what we can see in the presentation, everything looks nice, but the actual implementation is totally different. I tell you. Okay. In fact, when I give a talk sometime for newly elected governors, okay, and I talk about various topics, okay, when we talk about agriculture, the governors are not listening. Board members are not listening. Then they talk about sports, nobody wants to listen. But when they talk about health, everybody pulls their chair and then they sit down and listen. Why? Because 33% of the budget of the governors are actually on hospitals, excluding public health. That's only in hospital. In the case of Romblon, it's 55%. In fact, up to now, they have not actually adjusted their salaries. It's still at the level of 6 years ago, up to now. So I agree with what Professor Garilao mentioned earlier. Lahat yun, totoo yun. It's true. That's what we should do. But implementing it is a totally different thing. In fact, when we talk about hospital and budget, everybody listens. And then, sasabihin ng isa, in my province, I was able to reduce 33% to 22%. Everybody listens. Mine was 18%, you know, sharing and everything. And then there was one governor, I will not mention who. I will not even mention that he was a governor, former governor of Sarangani. He said, okay, in my province, I was able to reduce it to 2%. I said, wow. So everybody listened. Even I put down the microphone and listened to him. I said, what did you do? Very easy. I closed the hospital. How do you deal with the health problems? I bought brand new ambulances and then sent them to Jensen. Because, honestly, a lot of the governors, even as we discuss things right now, are actually thinking, let us renationalize all these hospitals. It is almost impossible to do it, but there's only one person I know who was able to do it, that Garcia, a Bataan, okay, to some extent, na renationalize, but he made it a career in Congress to renationalize it. Okay, so in a sense, we're stuck with this problem, but the problem is we have many examples of good governance. Okay, si Mayor dito has a very good program. A lot of governors have good programs. The problem is, will it last? What about the sustainability? Oh, okay, I tell you what. Okay, even if my wife actually replaced me, it's no guarantee that it will continue, whatever practice you have. Not that she replaced me. But the thing is, continuity is always a problem. And this is what I always tell everybody when it comes to health. Okay, health is not so much about technology. It is about financing. And if you want to approach health in this country, you should approach it in a manner that there is financing because it's always a problem. Okay, 33% of the budget of the governor, and then I remember one time Sec Ona Sierra said, "You're pouring money into the municipalities. Wag muna. Bakit? You know, a lot of them are dysfunctional." I told them, "Di naman siguro. So make a study first." And I remember we were in Mexico at one time. We said, "Oh nga, Gov, 10% are dysfunctional." For example, you have a mayor, okay, who disagrees in every sense. All actions have an MHO who fights the mayor every day. And then sasabihin ng doktor, "I took the board one take and I'm a doctor, and this mayor did not even finish grade 6. And the mayor will say, "Well, you try winning an election first. Then we can argue." So it becomes, that is a tendency, a practice right now. People will say, "Well, the MHO should do this." Do you know that a lot of municipalities don't have any MHOs? And if they're actually appointed by the mayor, okay, what happens is they're actually under the mercy of the mayor also, the programs. If you do not dispense any medicine without my signature because they might belong to another party. Okay, that's very, very common. Okay, I mean, we can talk about studies, but the reality is, this is the reality. Okay, my mother is a mayor of one of the towns. I actually approached her and said, "Can you replace your mayor, your MHO?" Why? Because she's already old, she's about to retire. She cannot see anymore. She cannot even hear. And she does not talk a lot. So it's a deaf mute doctor, but she's afraid to replace her because she's got 1 year to go. But if that was appointed by, say, DOH, then we can tell the doctor, "Can I put you on a desk job first? Get a younger one to replace you." But we can't do that right now with the system that we have. So it's kind of difficult to implement all these ideas. You know, the best time that we have a measure that we implement and it comes out with a good result is when mayors, when the politicians sit down, okay, and talk about the problems of health, okay, in detail, and they talk it in a language that they understand, not in medical terms. It's always about financing, okay, because my target, as far as I'm concerned, is to bring down the 33% to maybe 8%, maybe 10%. There's always a subsidy. Government always subsidizes. And they said, "So what will you do with the rest of the 33 minus 8? Okay, will you put it on agriculture?" No. You put it on public health. Because sometimes public health don't have any budget because it's being siphoned by the hospitals and the facilities. Okay, so I won't, I think I'm running out of time already, but one thing that I can tell you, okay, from my experience, being a person who actually implemented it and who faced all the problems, and I have to worry about re-election all the time, okay? Because sometimes development and political are in different directions, okay? So you have to actually, if you want to serve more, you have to win. But if you have to win, you have to be inefficient. Because you talk about politics. So there's one thing, I always say there is hope in the healthcare system in this country. Why? Because all of a sudden, we have PhilHealth. PhilHealth is about financing. In the past, I would say 6 years, if you look at the provinces, their performances have actually gone up. Okay, why? Because there is PhilHealth. You know, I always tell everybody that, you know, there's a lot of doctors here. I hope you don't feel offended, but this is what I tell the doctors, my doctors in Leyte. I will always pray for your compassion to serve the poor, but I cannot rely on it. The only thing I can rely on is conditional cash transfer. Honestly, okay? If you look at it in the long run, it's all about incentives, okay? We can disappear as governors, as secretaries, but in the end, it will be sustained if the financing background is correct. Now, the healthcare of this country relies heavily on PhilHealth. Okay, it has improved in my own personal experience on LGUs. But the demise of the healthcare of this country also lies in PhilHealth. If they actually implement wrong, like, I'm sorry, I know there are some people here who are very adamant about NBB, no balance billing, but I tell you, the no balance billing will kill whatever benefits or gains you have had so far. The no balance billing will kill it. Can I just, do I have time? Or
1 minute.
1 minute. Can I have the slides? Okay. This is this slide. Okay. This slide is actually actual. This is for 2014. We were hit by Yolanda. Because we were hit by Yolanda, PhilHealth said cover all. In other words, whoever goes to the hospital is assumed PhilHealth enrolled. Wow. That's good. Other provinces were saying, what about us? Ang sabi ko sa nila, you just pray that you have Yolanda. Then you will have this. So anyway, after that, okay, starting January of this year, no more cover all. Okay? See, now you rely on DSWD and other people are enrolling PhilHealth. Okay? So, sabi nila, the president mentioned at one point, we are almost 100% covered with PhilHealth. And I said, thank you, Lord. And then I saw this data. In this data, 4 months, okay, only 66% have actually PhilHealth. Why do we know this? Because we paid for the rest. Okay, for the 33.79%, we paid for it. POC, point of care. And this is not an invented number. This is an actual number that we gathered in the first 4 months of this year. Okay. Next, the effect of NBB. Can we move on to the next slide? This is NBB. Okay. The package rate in the private is actual in a private hospital in Leyte. 35,000 for the package. Okay. I'd like you to focus on the cost to patient and then the net. That is what the patient pays. Okay. We have a wrong computation there. 35,000 minus 6.5 is actually 28,500. It's still 28,500. If you go to the provincial hospital, the out-of-pocket is 2,224 because the published rate is 8,007. Then, of course, you have PhilHealth and so forth. Now, the profit for a private hospital is about 4,000. Okay, the subsidy of the provincial government, okay, with the rates that they have, is about 7,700. The cost of hospital care is about 16,000. This is actually normal delivery. 16,000 for private. I put 14,000 for government. I said, bakit 14,000 lang? Because the government, although they don't have the facilities, they don't have depreciation, all those things, their personnel are actually more expensive. Mas mahal ang gobyerno. So it balances out more or less. But the bottom line is this. Subsidy is 7,700 without NBB. Okay? With no balance billing, it becomes 10,000. And then you have POC, it becomes 12,400. If you look at the right portion, okay, this is the subsidy of the provincial government for a normal delivery if they did not participate in PhilHealth. Of course, this is just one procedure. You have many others. But I can show you that in the many other procedures, if you implement NBB, okay, I'm a numbers person, it will come out that at one point, it will not be worth it to actually participate with NBB, no balance billing. So I'm just saying at this point that, okay, healthcare, PhilHealth is the key to the success of healthcare in this country. But it can also push it backwards, depending on how they implement. I have never been consulted by PhilHealth at all on case rates. You have a case rate which is 6,500, okay, and that's actually 8 years old already. Okay, the healthcare in this country cost increased. Pero hanggang ngayon, 6.5 pa rin. I don't know who's reviewing it, but certainly I have never been consulted or any provincial governors for that matter. So, thank you for giving me the longest 2 minutes. And I'll give other people to react on the talk. Thank you.
Thank you. Can I give the floor to Bong?
Thank you. It's an honor to be here. My talk would be on the perspective of a hospital director or administrator for a high volume facility, that's Southern Philippines Medical Center in Davao City, integrating with the local government units in terms of the health system as a whole. Can I have the slides, please? Uh, First, the usual context is this. Uh, the local government units would usually run DOH community-based hospitals in the rural health or barangay health units, in nutrition, maternal, and later on they would think of, especially the local government units, they'd think of putting in curative care, and that's putting up a hospital, a city hospital, or a provincial hospital. Now, uh, basically, when you need a deep engagement in terms of the local government units in the overall health status of the community, you need to have certain ingredients. And one of these is the local executive must be very committed to health. The second is that in the Sangguniang, there must be a very functional health board. And then, of course, with its advocacy, you would have engaged populace and non-governmental organization, and of course with the partnership with the different organizations. Now, when you have this certain ingredients, it's easy to think of innovations, think out of the box, and then look at health in terms of the whole spectrum, not just on curative, but rather on primary, promotive, curative, and rehabilitative. And this is our experience in Southern Philippines Medical Center in terms with this kind of system with the local government unit. So for the health system in Davao, we are anchored as the Apex Hospital doing curative and rehabilitative. And sometimes we do and coordinate and integrate with them in terms of preventive. So this is the spectrum that we would like to see healthcare, from primary to rehabilitative. And what I'm going to show you are certain illustrations on how this was achieved in Davao. These are 5 examples of programs by the city government anchoring on us in terms of delivery. We have Lingap sa Mahirap. This is basically a social fund or a financial fund by the city government in terms of access to medicines, facilities, and maintenance of drugs. So in other words, you're talking here of a preventive aspect. Lingap sa Mahirap also helps out in terms of the subsidy of these patients when they need cure. And to the point that if they need wheelchairs for rehabilitation, if you're a post-stroke, Lingap sa Mahirap will also help out this kind of patients. We also have the smoking cessation, which is preventive and promotive, being programmed by the city of Davao. And we do have the pre-hospital care. And this is not just as ambulance, transferring patients from hospitals to hospitals, but rather this is a kind of care where there is on-the-spot resuscitation, heavily coordinated with our emergency room medicine physicians through telemedicine or through necessary communications. In other words, this is now a very mature kind of arrangement integrating with the local government program and in terms of the DOH institution like us. Then we have the CVD program, which is anchored by the city, which is basically focused on the medical condition, diabetes and hypertension. And they have asked the rural health workers and the barangay health stations to map out the different diabetics and hypertensives so that they can be monitored, given medicines, and once complication sets in, they refer this to us as a curative, whether they need dialysis, whether they need angioplasty, or whether they need coronary bypass. And if it is hypertension with possible stroke and disability, again, this would be referred to us for rehabilitation medicine, for physical therapy, and definitely for mobility later on with the processing of wheelchairs. So the last is the PWD mobility program, which I'm talking about. And this actually is anchored on those patients who still can be mobile and can still work, but in spite of their disability, we're giving them this kind of setup. Now, Lingap sa Mahirap, as a proof of concept, addresses the financial fund for the city of Davao. 80% of this, 20% comes from other places. And you'd notice from May 2016 to April 2017, there were about 73,328 clients served and 230 million in assistance to us. And that's the institution that I'm in, the Southern Philippines Medical Center. In terms of the primary care, which means maintenance, curative to its hospital admissions, so forth and so on. And we are going to deepen this more into in engagement with the local government unit by putting up a one-stop shop in our facility wherein the patients can access all the kinds of subsidies that they would need, whether it's going to be the medical assistance program, PCSO, or they would need the DSWDs. In other words, this will actually cover the financial aspect for patients to maneuver around primary care, and meaning to say the maintenance of drugs and detection of their blood in terms of diabetes, towards curative and rehabilitative. So this is the kind of setup that we have been trying to set up for the population in Davao City. The city government also has a very good program, which is actually very preventive, and we do advocate this. We also have the public health unit in our institution, which actually integrates with the program, and they coordinate in terms of the smoking cessation. So this is to address the triple burden of disease, deeper engagement, and of course there were more quitters, and this can easily be monitored. The other pre-hospital care and emergency response, as I'm telling you, is the 911, which is basically a curative form, but not just transporting, but rather it's going to be resuscitative on the site with the proper coordination with our base. Then we have the CVD program, which is actually anchored more on diabetes. Screen out all the diabetes, make sure that they get their maintenance, make sure that they have problems in terms of morbidities and complications. They get the right kind of treatment, and with the funding support coming from the city government. And then this is the PWD program that we've done. These are specialized wheelchairs. Last year we were able to give 271. This is with the coordination of the local government unit, wherein they would actually search out those patients with disabilities and plan out these wheelchairs. And these wheelchairs are customized depending on the weight, depending on the disability of the patients. We were able to give in last year 275 wheelchairs, and also special wheelchairs for CP clients. So in other words, these are cerebral palsy patients that need wheelchairs and has to be mobile. And we gave 73 for this. And this is in coordination really with another stakeholder, which is the LDS Charities, which actually provides a wheelchair, but we sustain them in terms of the funding coming from the city and funding coming from the medical assistance program. So I think that when you look at health in terms of a spectrum, and not just primary or curative, but rather the whole spectrum, and look at the medical conditions on how best we can approach this, I think if we do this together, we can achieve universal health care. Thank you.
Okay, thank you. Before I give the floor to Mayor Coro, maybe just to annotate, we actually have two interventions really about hospitals. The first intervention of Governor Putilla talked about the provincial hospitals, which really are congested, and for which the province is actually subsidizing more than what it's getting. When you listen to the presentation of Bong Vega, he's talking about the tertiary hospital, and actually talking about the tertiary hospital trying to do primary care, pre-hospital interventions, and so on and so forth. So really, it tells you what the phenomenon is in our country. You're actually having the constituencies, our citizens, directly going to the hospitals, congesting it. Because the question you might ask is, Are these the type of patients who should be seen in the hospitals, where it's actually more expensive to care for them? And I say that at the point where our next speaker is actually a mayor who's in charge of a rural health unit, which is not a hospital, and which, as we know, will service most of the poor patients who may need care. So, Mayor Cora?
Good afternoon to everyone. I feel honored to be here with very distinguished guests. To share experience, there are two things you have to remember in a rural municipality. One, you don't have enough resources. Your ERA might not be enough for anything except a salary of your local government unit. Number two, your constituents are poor. If they earn only 2,000 or 3,000 per month for a family of 5, if you split their monthly expenses, there's nothing left for health. Which means, given those two conditions, your poor communities will only go to the facility of a rural health unit which the local government cannot afford to maintain. Right? So those are the conditionalities. And we were glad that in our experience in the last 7 years that we've been running a health program, it's anchored on governance, which was what we learned from Professor Garilao and the Zoilig Family Foundation. Appreciating public health, especially on preventive and promotive health, not the curative, which we really cannot afford. It's really anchored on communities. Communities that will band together, including other stakeholders in your community, not the mayor, not just the MHO, but the church, the barangay leaders, your barangay health workers, your fisher folks, understanding and appreciating health. Earlier this morning, Asek Tayag mentioned about health literacy. That is actually what we did. We made sure that every constituent in our municipality appreciates and understands their role in ensuring a healthy community. Because we cannot afford curative health, we made sure that they know what needs to be done to make sure that we won't get to that level. Recent developments in our health system, in the presentation this morning, everyone was focused on womb to tomb. Right now, what is required of the local government units are pre-womb because you have family planning. So before they get into the womb, you start planning because that will be part of your preventive and promotive health. And that's what is expected of local governments. And in ensuring that you have that quality care, you have to make sure that you have committed human resources. And we have DOH to keep them trained, to give them as local government units. You have to make sure that they're constantly committed. Sabi nga ni Gov, I love your compassion, but I need the 4Ps. The 4Ps is another intervention that is heavily used in the local government unit so that you can make sure that we do preventive health. They need to go to the rural health unit or barangay health unit so that they have their regular checkup. Again, to prevent people from going to hospitals. Because if you get early detection, early diagnosis, then the referral might not be to your regular district hospital. It might be to another hospital, but the cure might be faster. And again, it's all about health-seeking behavior that will improve through health literacy. And in ensuring the sustainable gains of what we have done, wherein people are now regularly, both the health unit visiting the barangay and the constituents visiting the health unit, there is now regular checkup, which means the regular target diseases are already addressed. So now, our local government unit was able to expand our services already. For example, we're now focusing on inclusive PWD, not really to cure them, but to at least make them become part of the community. And other aspects includes every local government, especially every barangay, have their own health issues, which are different from every community. An upland barangay will have a different health issue versus an island barangay, versus an urban barangay, versus an inland barangay. For farming barangays, you have schistosomiasis. For beachfront barangays, you may have HIV, which is not prevalent in an upland barangay because nobody will go there. All of your tourists will go to the beachfront. So all of these different concerns are being addressed in the barangay level. And every different health issue, considering your Pareto principle, if you address, let's say, it's an HIV concern for a particular tourist barangay, it might already address all the other concerns. And it doesn't entail a lot of cost. And that's because we have to do it that way. And we were able to do it because we were trained how to do it. And the governance model is really critical, especially in rural government units. Probably not in urban, wherein your health, again, health concerns a little bit different. You talk of hospitals, you talk of private practices. We don't even have a private practice, even if we are an emerging tourist destination. So there's a lot of complexities that we have to deal with, and we have to do it with very limited resources. And I hope all these discussions about primary health care will go back to the very simple thing that I think all of us wants to do. It's to make sure that the patient, hopefully, when they go, they don't have to go to the hospital regularly. That's the only way we can reduce cost. At the same time, manage the health services, maintain that quality of health services we can do. So if the DOH continues its advocacy on governance and health literacy, I think that's the right path to ensure primary health care. We have experienced it. We have our numbers to show that it has good results, especially if it's done correctly. And then thereby lots of your other resources can be focused on ensuring that we can have specialized healthcare to support the tertiary care or third delays that needs to be addressed in other different communities in our country. So that's it. Thank you.
Thank you very much, Mayor Coro. What I take away from your presentation is the fact that even in one municipality, you have different constituencies. And it's important that the health system addresses those different constituencies, which actually is a good segue to our next speaker, because we're talking about, either of you, essentially special constituencies, women with breast cancer or those we don't want to have breast cancer, and the elderly. So who'll go first, Cara or, okay.
Good afternoon. I'm not a health professional, so I'm not going to speak from the perspective of health practitioners. Doon lang ako sa perspective ng mga pasyente. Allow me to read. I wrote down some things so I won't forget, senior moments. Allow me to read. Health is a basic human right. The United Nations declared everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care. Article 13, Section 11 of our Philippine Constitution also states that the government, the state, shall adopt an integrated and comprehensive approach to health. Much as we have heard of the President, the administration's openness to providing for whatever we lack in terms of medical sufficiency, I think no amount of resources of government can adequately ensure the health and well-being of all the Juans and the Juanas without the concerted efforts of all sectors and stakeholders. While traditionally, health issues concern only our doctors and nurses who were considered Considered as the health experts, this country is now in a crisis. In 2013, a group of health practitioners and health advocates banded together to form the Coalition for Health, the Primary Care Coalition. And they declared in 2013 that there was a workforce crisis, meaning there is so much possible healthcare professionals who should be serving the population in the Philippines who are getting out of the country for more lucrative jobs overseas. So to fill the void left by the health professionals leaving the country, the family and community has to take a more proactive and contributive role in the promotion of health in this country. After all, in the olden days, where that's where I come from, health was the primary responsibility of family, not of doctors. Bihira ang may doktor na munisipyo noong mga panahon na yun. Early on, a child must learn the basics of food and nutrition. Poverty need not define the health of the people. Food sufficiency was achieved through the bahay kubo approach. Kailangan lang talaga magsipag yung mga pamilya. So walang gutom, pag walang gutom at sufficient yung nutritional value na nakukuha ng katawan, there was lesser chances of people getting sick. Given primary care, serious ailments could be avoided at the time. Sanitation and cleanliness was everyone else's responsibility. The family and community at this time can also serve as support system for those with family members who contract catastrophic illnesses. And members of the families or members of organized groups in the community could be trained to do home care and take care of those who are bedridden and who have no families. And this will, in fact, will augment the barangay health workforce. Alam naman po natin sa ating barangay, ilan lang ang barangay health workers. 2, 3, and you see them only once or twice a year. Kung magtitimbang ng mga bata, magsusukat. But otherwise, you don't see them coming every so often. And we think na since sa kultura po ng mga tao natin, especially in the rural areas, people do not usually go to health centers or to hospitals unless andoon na sila malapit na sa dulo ng kanilang buhay. Kung hinihintay natin yung mga tao to seek services mula doon sa mga health centers, chances are ilan lang ang mag-a-avail ng mga serbisyo. What we need, I think what we need is also for government to be proactive na once in a while siguro yung ating mga health service providers should go to the community, puntahan ang mga bahay-bahay. And ang nakikita po namin dito, yung ating community can be trained. Some of the members of organized groups can be trained to do the basics of healthcare, basics of home care, the basics of what to do in case may mga nangyayaring mga emergencies within the community. Maybe pwedeng tulungan, bigyan ng seminars, bigyan ng training. And this is where we expect also the local government units to invest in the capacitation of the families and members of the community who might be interested in helping promote health. 2 years ago, I drafted a proposal for a community kung saan we offered the services and the time of older persons Kasi alam naman po natin, pag tumatanda yung mga tao, 60 years old and above, wala nang pinalalaking anak yan, karaniwan. So we have much more time in our hands. Na kung bibigyan kami ng pagkakataon, we can be trained on the basics of home care. We can be a replication of the barangay health workers. Ang kailangan lang naman ay konting expense ng gobyerno in terms of training us. And then maybe something for the transportation, pang tricycle o pangbili ng biskwit pag nagugutom. Yung ganong tipo. But kasi ang mga tao naman, I mean, as a community, they can participate in cleanup drives, campaigns, information, education campaigns within the community, and even, in fact, lobbying in the local boards, in the local sanggunians, or even up to the national. Kami po, nagawa namin yan, yung grupo ko, yung COPAP, Confederation of Older Persons Associations of the Philippines. Kami po yung nagsulong ng provision for social pension doon sa Republic Act 9994. We have ourselves to blame para po doon sa SOCPEN kasi maraming problema ang implementasyon. But anyway, we participated in the campaign for the cheaper medicines. In fact, kahit po yung anong tawag nito? Yeah, pati po yung sa syntax. Yung Republic Act 1994. And nangingialam po kami as part of the Alternative Budget Initiatives Group. Nangingialam din po kami sa budget ng DOH annually. Nangingialam kami doon. So, many things can be done kahit po yung mga hindi masyadong nakapag-aral sa ating komunidad, po pwedeng ma-harness ang kanilang mga resources, sila bilang resources. In fact, many municipalities don't even have the ambulances. Pero po pwede pong ma-organize ng isang munisipyo, sino-sino ba yung may mga transportasyon within the community who are willing to make use, to donate their services and their facility para dalhin yung mga taong nagkakasakit na kailangang dalhin sa ospital. Yung mga ganitong na hindi naman kinakailangang pagkagastusan ng malaki ng ating gobyerno. This is just a footnote, rejoinder po doon sa topic earlier today about the primary health care system, kung saan we very much appreciate yung ganoong plano at saka we're hoping na ito po ay talagang naipapatupad, na-implement. However, my only issue there is hindi ko po nakita doon bilang bahagi ng organizational structure yung mga tao sa komunidad bilang actor, bilang bahagi ng positibong contributor doon sa service delivery. Ang nakita ko lang po doon is that, and I think this is one of the reasons why our healthcare system also nagkakaroon ng mga failures, is that we consider the community, we consider the people as patients, as passive recipients of service. We don't consider them as part of the solution. Hindi natin nakikita maraming resources na maaaring maibigay ng ating komunidad. Thank you very much.
Thank you. Thank you very much, Ms. Luciano, for reminding us of the role of families and of the role of communities. And well, our last speaker, Cara.
I'll speak for less than 2 minutes. I promise. So you can go to my website to know more about what we do, icanservefoundation.org. I'd like to acknowledge all the VIPs, but in my universe, the patient advocacy universe, my rock stars are the barangay health workers. They are the major drivers of our programs. And one of the leaders is here with us, one of our partners, the chief of the City Health Office of Muntinlupa, Dr. Thank you very much for all your help. It's people like them who make programs work and even the Philippine Cancer Society, Romy Marcaido. Thank you for your help. They are our partners in a program called Ating Dibdibin. It's early breast cancer detection program, community-based. We make it permanent through an ordinance. I'm not going to tell you about it because we're going to run out of time. All I can say is that when you partner with local government, and you have to come in it with a lot of humility because the buy-in takes so long. But once you get that buy-in, the rewards are immense. They embrace the program, they put their own stamp, they make it more creative, they sustain it, no matter if they are resource challenged. We've seen this in our partners in Panabo City. They really have barely anything, but they still manage to give free mammograms, free chemotherapy, and free ultrasounds to their patients. They find a way, they struggle, but they do it. So when I say they innovate, for instance, in Muntinlupa, they do a lot of breast cancer campaigns in the malls. In Taguig, they do it in the universities. In Taguig, we only asked for a few patient navigators, but they gave us training for breast cancer patient navigators per barangay. If I'm not mistaken, they have 28 barangays. And to your point, ma'am, in one of our partners, the patient navigators actually have allowances for cell phone loads to track their patients. Yeah, they have transportation money, all that we talk about. But again, you can go to my website to know more. So in case I lose time, I just want to pose questions. I want to spend time to have some questions answered. I'd like to ask Undersecretary Panadera, and maybe Mr. Garilao can chime in, about what you think about the creation of like a patient feedback mechanism embedded in LGU, whether the city level or the barangay level. It's not a grievance committee. It's more like you can see them as partners in delivering effective healthcare. I think, like to your point as well, and in our experience, the support groups we've created are actually the feedback mechanisms. When you partner with patients, they become part of the solution as well. So in our case, they have helped patient navigation, and they've also helped implement the programs, especially where personnel is, always short. So there's a lot to be gained from this patient feedback mechanism. You can have a rich relationship that, when they share information and knowledge and there's trust, I think a lot can be accomplished. And I think, if I'm not mistaken, it's part of a provision in the Universal Health Bill that's pending. Whether or not it is, I also want to know what you think about it, and how can you ensure its independence from, let's say, political influence or even commercial influence, especially if it's going to be funded by the local government. Can this be funded by the national government, or how do you propose to go about this? But I think it's about time that the patient's voice is also put at the center of all these programs. I mean, that's the reason why we're all here. It's less than 2 minutes. Thank you for inviting me.
Thank you very much, Cara. Well, you've heard the 5 panelists. I don't know what your takeaway message is from all of this, but mine is we really have a very, very hospital-centered system, and you can see it in the congestion of the hospitals. While the primary level, the families, the communities, preventive care are sadly under-tapped, and the potential there is not even being tapped, particularly for preventive care. So anyway, we have time for questions, so can I ask those that want to ask questions to line up in the microphones? We'll take about 3 or 4 questions at a time and shoot them to the panelists. And while you're lining up, maybe Yusek Panadero, you could answer the question of Cara.
Thank you, ma'am, for that. Well, just thinking aloud, no? The first thing that comes to mind is the feedback is fine. I mean, if we have an organized group, and I would assume there is an organized group, mga sectoral groups natin. But the question comes to mind is who is going to receive this and act on it? We need to think of the structure, siguro, that needs to be put in place to really make sure that these are acted properly. Now, then you added the dimension of independence. So therefore, baka that is a model that we need to create, wherein there is a local government and a private sector, which means, ma'am, yung binanggit niyo po, the role of the families and the communities in every town or city, baka that's something that we can evolve. And if there are models already in some parts of the country, that can be scaled up. Yeah. Basta Mayor, baka may ginagawa niyo.
Actually, ma'am, that's already being practiced in most local governments. We have expanded local health board wherein you invite different stakeholders, then every month or some other local government units do it quarterly. They review feedbacks, comments, but mostly comments that we see are comments versus the mayor. Like, we're not giving pamasahe, we're not giving gamot. It's not us to give the, so it goes back to the interventions that we saw. Again, I'm speaking for rural communities, not urban. The interventions that we saw was basically more on health literacy. Let them understand the role of health in their communities and the difference between politics and health. Because a lot of the communities are still so much involved in the concept of the mayor will solve all their problems. That's why I voted for you. Right? So now we're trying to change that concept that the mayor is your partner together with you in developing the community we all live in. So that's why it's health governance. For the past few years, we've been going around different municipalities and regions to try to convince mayors to work on their governance modeling so that they can use it also for their political gain. It would be nice to hear a mayor campaign to say that in my municipality, I can assure you that no mother will die giving birth. And that can translate to votes. Right? Kaysa sabihin mo, kunwari, ako mayor, sabihin ko sa isang munisipyo ko, huwag kang mag-alala, nanay, sa 10 manganganak next year, 2 lang naman mamamatay. O, di ba? So, if it's how you channel the health literacy so that your political leaders can also appreciate health. And also, your community will also appreciate that your political leader is serious about health in your community.
Okay. We don't have that much time for questions, but I'm told that we only have time for 2 questions. So the gentleman over there in green and the lady over here. And I'm sorry for those that have stood in line, but please, could you ask him to ask his question? I think that's Mateo Lee. Oh.
Thank you very much. I'd like to be very brief. I'm Matt Lee from NCDA, National Council on Disability Affairs. I'd like to react to the statement of Governor Petilla that to be able to win, you have to be inefficient. And the comment of the good mayor from Siargao, as just says, it's always limited budget that we cannot be responsible in answering all the patients' concerns, including persons with disability. My idea is it not possible for the governor to convene all the municipal mayors, and all of you are being given ERA? Can you not share on a project to be able to ensure universal healthcare? For example, you form all experts of rehabilitation professionals to visit one municipality on a schedule so that it will be made available in every municipality of your province. Because the municipality has different classification. You have 1, 2, 3, you have 4, 5, 6. So therefore, the 4, 5, 6 would be very difficult to answer inclusive health. But the 1, 2, 3 can help them. And I think this is the idea of federalism. Can you comment on on that idea? Thank you very much.
Okay, before you comment, could I ask, please, to ask your question, then we'll have the panel respond.
Good afternoon. I'm Girly Lorenzo from the Philippine Alliance of Patient Organizations. Actually, my question is directed to you, Sec Panadero. Is it possible, sir, because we are already on organized patient groups, that we can work with the ILG to establish PAPO chapters at the LGU level? And is it possible that one of the criteria for a good governance, you said it, the seal of good governance will be the existence of an effective and working patient feedback mechanism group on the ground, so that Juan and Juana will have a voice and will really hold the leaders accountable in the delivery of a good health program?
Thank you. So can I ask Governor Petilla and then Yusek Panadero?
Thank you very much for the earlier reaction. What I really meant was this, okay, I actually come from a private sector. I have my own BPO, I employ 4,000 people. I measure productivity down to the last bit. I'm happy to say that in my company, I'm 92% productive. But when it comes to government, I tell you, it's very difficult even to reach 80%. So to some extent, okay, being in the government is actually inefficiency because of bureaucracy. There's bureaucracy involved. Of course, you have also the politicking involved. I'd like to make my mayors, my former mayors anyway, to become like the mayor of Siargao, where they actually go to the last detail. It's actually a comprehensive health program. Because Yusek Panadero, you were saying earlier, the problem that we have is that we have a compartmentalized health system. Okay, I will not put up my hospital there. Why? It's another province or it's near another province. But to some extent, again, this is not hitting on DOH also because we want a comprehensive health system. Okay, and having it involves financing as well. The doctors in Leyte receive an average of 200,000 a month without any money coming from provincial government. It comes from PhilHealth. That's why the key really is there on PhilHealth. But we have to go beyond. It has to be comprehensive in a sense that we don't stop in the provincial level only. It has to be region. And if you talk about region, talk about nationwide. I'll give you an example. The mayor is highly dependent on the acts of the governor. The governor also is highly dependent on the actions of the regional director of DOH. I'll give you an example. Okay, there is a tertiary hospital in Tacloban City. There is another schistosomiasis hospital in Palo. Leyte also. They're about 20 minutes from each other. It's okay. You can have as many hospitals as you want as long as they're specialized. But when it was converted into a general hospital, and then the intention is to make it a 300-bed hospital, I cannot understand why two tertiary hospitals, 20 minutes from each other, will have to be operated. The ideal situation is two hospitals, okay, 2 hours from each other, and then in between, that's a DOH hospital, okay, tertiary hospital, and in between, you have the district hospitals, okay, which will also cater, okay, to the public health options of the mayors and the governors. Pero sa ngayon, that schistosomiasis hospital, for example, is only 1 kilometer away from the Leyte Provincial Hospital. So when they announce it, my initial reaction is because we don't have enough money. I told the governor, I think it's about time you close the Leyte Provincial Hospital because you have many hospitals. Put it on public health. Put it on actually mayors and barangay health workers because again, we will support the DOH hospitals in this manner. So it's a matter of actually managing the meager resources that you have. And it has to be comprehensive. It cannot be compartmentalized.
Okay.
When we developed the program initially we developed the program for mayors and governance. And the assumption there was that even without any intervention from the governor and from the DOH, what can the mayor do? And you have the governor, you have the mayor as a fine example. You know, because basically I said, yung models na to is really, in other words, he's not, he can be dependent on the governor or DOH. But as a mayor, he has resources that he can turn around. And he has resources that he can move around insofar as health is concerned. Provided he has the health literacy and the governance and the commitment to do the same. That is the logic of it. Because if we are going to be if we are going to get integrated with all the system, I cannot do this because I'm here. Walang mangyayari sa atin because the rest of the systems are locked in. Ganon ang kwada. Anyway.
Okay. Just last comment, si Yusek Panadero.
The quick answer is yes. If you don't mind, we'll bring in lang DOH to this working group and we can start working together as soon as possible.
Okay. Well, thank you very much. This closes this session, and I'd like to thank the speakers and the panelists for their inputs. Thank you very much to the audience for their
Thank you, Mr. Ernesto
listening.
Garilao, Undersecretary Austere Panadero, Mayor Alfredo Coro, Mr. Jerry Copitelia, Ms. Cara Alicpala, Ms. Salvacion Basiano, Dr. Manuel Deirit for the engaging discussion on LGU engagement towards healthier communities. Second part of this afternoon's series of panel discussions is operationalizing requirements making primary care Land USA, and a PhD in economics from the Maxwell School of Citizenship and Public Affairs, Syracuse University in New York. He is Professor Emeritus of the University of the Philippines, Diliman. He served as fiscal advisor to the Philippine Senate, as chairman and CEO of the Philippine National Oil Company, and chairman of the Local Water Utilities Administration. Let us give a warm round of applause for Secretary Benjamin Diokno.
My co-workers in government, friends from the media, guests, ladies and gentlemen, good afternoon. After listening to the conversation here, maybe I don't want to read my prepared speech. You know, I was part of the team that prepared the local government code of 1991. Okay, so in the original bill that we submitted to Congress, health was not part of the decentralization. What we intended to do was to decentralize education, not health. Okay, not health. Okay. But in the process, I remember the name of the education secretary. Education Secretary Carino. He's so cariñoso, right? And I was able to convince the Senate and the House that decentralization, that education should not be devolved. But there was already an agreement to give the local governments 40% of the ERA. So I think there's a veiled threat that we teachers actually administer the elections, so if you devolve us, you might be in trouble, right? So the education was taken out and health was replaced. Okay. Why? Because at that time, the health secretary was Alran. And of course, Alran didn't like the congressmen and senators, and they didn't like Alran also, right? Smart kid, or a smart man. But so that's what happened. So it took us almost 3 years to complete the decentralization, as you know, because this is the bloodiest of all the, because we decentralized agriculture, social welfare. Social welfare is easy because they are really there at the grassroots level. Education was the bloodiest, right? And many of the doctors, they just decided to resign, okay? As Governor Petilla said, why should I work for a governor that has no respect for my profession or something like that? So now, after hearing this conversation, I'm now more than convinced that this is a failed experiment. I don't know about you, okay? Because there's been a creeping recentralization anyway. We devolved the regional hospitals. Now the regional hospitals are back in the department. We're financing it. And now in the most recent cabinet meeting, Mr. Tayag is here. He will report me to Secretary Ubial. They were talking of the Cuban model. But the Cuban model is a centralized system, right? It's a centralized system, not decentralized. So how do you tie this up? And Secretary Ubial was asking for all sorts of money, right? So I said, we have to really come up with a comprehensive solution to this. And the sooner we have that, I think the better. We cannot go on like this because the budget of the health sector budget is now around 160 billion. It used to be only around 20 billion when it was not decentralized, right? So we're spending a lot of money at the national level. And so my next question is, what are the local governments doing with their money? They're supposed to spend money for health also. The era right now is in the neighborhood of 600 billion. That's the era of local governments. Okay? 600 billion. Okay? They will only spend 10% of that for health. That will be a big sum, right? So, what should I? Do you want me to continue reading this speech here? Okay. So anyway, I guess that there's some numbers here that are quite revealing. We, as expressed in ambition, not in 2040, we, the Filipino people, aspire to become strongly rooted, to live a comfortable life, and to live in peace and financial security. Matatag, maginhawa, at panatag na buhay para sa lahat ng Pilipino. This is our dream, our vision. As we are committed to the golden age of infrastructure, and you've heard of that, build, 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 we propose to spend something like 8 to 9 trillion pesos for infrastructure. Because we're the poorest, we have the poorest infrastructure in this part of the world. Okay? But together with this, we are also committed to invest in human capital. Why? Because of our young people. The median age of Filipinos is 23. That's an asset in an aging world. Okay? In an aging world, that's a formidable asset. But we have to educate them, we have to provide health care, and we have to provide proper nutrition. Okay? So, and that's what we plan to do. Not only invest in physical infrastructure, but also invest in the human capital. We want to convert our youth into an agile, competent, and healthy workforce. Okay? And so this strategy does not only demonstrate the administration's deep regard for those who are in need, but also secures more productive members of society. When people, especially the young ones, are fed properly and have access to health interventions, then they are more likely to attend school, perform well, and secure for themselves an education. So that's for the 2017 national budget, the first budget crafted under the Duterte administration. A sizable amount has been allocated for the health sector. 158.3 billion. That's the amount. Okay? Will be used to fund the expenditures for hospitals, outpatient and public health services, health insurance, and research and development on health. This is an increase of 19.2% over the 2016 level, allowing a faster and improved delivery of service to the people. For hospital services, this budget, the budget for this year is 54.7 billion, which is 20.3 billion more than the 2016 budget. Health insurance funding is increased from 43.8 billion last year to 53.2 billion this year. With a strong and steadily growing economy, we now have the necessary funding to support our health programs, and we intend to use these funds effectively and efficiently. We will not tolerate underspending because this means denying the Filipino people the service they paid for. Although I've looked at the health budget for a long, long time, and they are always guilty of underspending, right? The health practitioners here. Statistics show that we have made some strides with regards to healthcare. The Philippines was made to meet its Millennium Development Goal commitments on reducing child mortality by 2/3 between 1990 and 2015. We have also been able to halt the incidence and prevalence of major diseases such as malaria and, to some extent, tuberculosis. Nevertheless, we have to make up for a lot of ground in aspects such as reproductive health, maternal health, accessibility of health care, among other things. And this is especially true given the more ambitious health targets set by the Sustainable Development Goals of the UN. With a human capital buildup and pursuit for quality and accessible healthcare, the 158.3 billion health budget for 2017 seems only rational. Healthcare is not just for those who are well off. So I'm convinced that maybe we should review the Decentralization Act, because your access to health should not depend on where you live, right? Whether you live in a small barrio in the north or in the south or in Makati, I think you should get the same health care. Okay? In fact, there is now it is very attractive, especially if you're a senior, to live in Makati, right? Because you get the best health care in the country. So it's basic right that somebody pointed that out. Healthcare is a basic right, and our goal is to provide all Filipinos, especially the poor and the elderly, access to health facilities that are capable of giving quality medical care. Thus, the amount of 98.4 billion, or almost two-thirds of the total health sector budget, has been given to the DOH. This is an increase of 21.4% over its 2016 level of 81.1 billion. This budget will be used by the DOH to implement various preventive and promotive health programs. And let me show you some of their programs. First, the Health Human Resource Program. This is a serious lack of medical practitioners in the country, and we intend to solve this. So for 2017 alone, 7.4 billion will be used to hire a total of 435 doctors, 15,321 nurses, 3,100 midwives, and 243 dentists to alleviate this situation. This is only a start. Okay? These medical professionals will beef up the manpower for the doctors to the barrios and the rural health practice program. Early Childhood Care and Development Program. This program, spearheaded by the National Nutrition Council, has been allocated a budget of 294 million. Through the ECCD program, 9.3 million children below 5 years of age will be given essential vitamins and minerals. Third program, National Immunization Program. This year, we have allocated 7.1 billion for National Immunization Program. This will allow the immunization of 2.4 million children across the country, or 200,000 more than the target number of beneficiaries in 2016. Further, 3.1 billion of this budget will be used to purchase dengue vaccines to continue our fight against dengue. Other infectious diseases program, 2 billion pesos are allocated for other infectious diseases program. This is intended to minimize the public health impact of infectious diseases, as well as promote preparedness and responsiveness to emerging and re-emerging infectious diseases. Fifth program, tuberculosis, 1.3 billion will be used for that tuberculosis control program in order to reach the treatment success rate of at least 90%. And then the Responsible Parenthood and Reproductive Health Law. The Duterte administration is committed to strengthen the implementation of the Responsible Parenthood and Reproductive Health Law. Thus, 4.3 billion has been allocated for the family health and responsible parenthood. This is 87% higher than the 2016 budget. This will be used to educate low-income couples in financial and family planning. There's a huge program called Health Facilities Enhancement Program. Okay? So in addition to the government's vigorous infrastructure program, we will also strengthen the healthcare system of the country by constructing new hospitals, drug rehabilitation centers, barangay health stations, and many other health facilities, while existing ones will be upgraded, expanded, and repaired. Of the 24.2 billion budget for this health facilities enhancement program for 2017, 12.7 billion has been allotted for the health infrastructure program, while the remaining 11.5 billion will be used to procure medical equipment for the new and upgraded healthcare facilities. Meanwhile, the National Health Insurance Program is granted 53.2 billion. This budget will be used to ensure that low-income individuals remain healthy and capable of supporting themselves and their families through their jobs. This allocation particularly targets the poorest, including those from informal sector and the senior citizens. Specifically, the targeted beneficiaries of the National Health Insurance Program are 15.5 million indigents, families identified under the National Household Targeting System, 5.5 million poor senior citizens, and 48,221 PAMANA grantees. And finally, we have the universal health coverage. So Congress, in the 2017 budget, decided to have full coverage for the field health. So you don't have to produce an ID. You are covered by definition. Okay? So this ultimate goal, the ultimate goal of this program, is expressed by the President in his State of the Nation address, is to provide field health benefits to all Filipinos, whether a field health member or not. So we can realize our vision of a matatag, maginhawa at panatag na buhay, and this will be easier as we improve our country's health system. The government is thus making sure that programs and projects focused on the health of Filipinos are well-funded and well-managed. So to my co-workers in the government, let us use these funds efficiently and effectively. Finally, let us all support these programs and projects. These are for the ordinary men and women who dream for and work hard for a safer, fairer, more beautiful, and more prosperous Philippines. Thank you and good day.
Thank you, Secretary Van Diokno. May we request you to please post your insights on the UHC wall. Thank you, Secretary Diokno. We are honored